Hey there, and welcome. Today we're diving deep into peptic ulcer disease. We're going to build a visual map of its pathophysiology, hitting all the key concepts you absolutely need to know for your exams. By the end of this, you'll have a super clear mental picture of how this disease works, how it shows up, and how we treat it. Let's get right into it. All right, to get our brains warmed up, let's start with a classic clinical puzzle. Why is it that with one type of ulcer, grabbing a bite to eat makes the pain so much worse, but with another type, eating actually makes you feel better? Just hang on to that question because we are going to build the answer together step by step. So before we can even talk about how an ulcer forms, we first have to appreciate the stomach's incredible defense system. I mean, think about it. It's a bag of powerful acid, but it has these brilliant ways of protecting itself so it doesn't get damaged. And here's the secret. The stomach's lining is packed with mucus glands. These glands are constantly producing this thick, slimy, alkaline layer. It's basically a force field that neutralizes that powerful hydrochloric acid. This is what stops the stomach from, well, digesting itself. It's this perfect, delicate balance between a powerful offense and an amazing defense. But what happens when that perfect balance gets thrown off? What happens when that protective shield breaks down? Well, that's when the stomach lining becomes vulnerable, and that's when trouble starts. So let's meet the two main villains that are famous for breaking through these defenses. On one side, we have H. pylori. It's this tough little bacterium that can actually survive in the stomach's acid. It burrows into that protective mucus, setting up shop and causing chronic inflammation. Then, on the other side, we have the long-term use of NSAIDs, things like aspirin and ibuprofen. These drugs block chemicals called prostaglandins, which are absolutely essential for. And what happens next is like a domino effect. First, that protective lining gets damaged by either H. pylori or NSAIDs. That injury triggers the body's alarm system, inflammation or what we call gastritis. Now with the shield down and the tissue inflamed, that powerful stomach acid can get right in and start eroding the unprotected wall. Over time, that erosion digs out an open, painful sore, and that, my friends, is an ulcer. It's a very clear step-by-step breakdown. Okay. Here's a really important point. Not all peptic ulcers are the same. Their location makes a massive difference in how a patient feels. So let's break down the two most common types. Gastric ulcers, which are in the stomach itself, and duodenal ulcers, which are in the very first part of the small intestine. Getting this distinction is the key to answering that question we started with. Let's really look at these differences, because they're huge. With a gastric ulcer, you get this gnawing, sharp pain about an hour or two after you eat. And here's the key. Eating makes it worse. Now, for a duodenal ulcer, the pain is more of a burning feeling that shows up later, maybe 2 to 5 hours after a meal, and it often wakes people up at night. But here's the twist. Eating actually makes it feel better. The bleeding signs are different too. If you see someone vomiting blood, that's hematemesis. You think gastric. If they have dark, tarry stools, melena, that points more towards a duodenal ulcer. All right, so here it is, the answer to our big question. When you eat, your stomach starts pumping out acid to digest that food. If you have a gastric ulcer sitting right there in the stomach, that fresh wave of acid immediately irritates the raw sore. Bam! Instant pain. But if the ulcer is downstream in the duodenum, the food that's just arrived from the stomach actually acts like a sponge, soaking up the acid for a little while and giving the patient some relief. The pain only comes back later, after the food has moved on and the stomach is empty but still making acid. And there you have it. Okay, so we've solved the pain puzzle, but now we have to talk about what happens when things go really, really wrong. Because an uncomplicated ulcer is one thing, but a complicated one can become a true medical emergency fast. And this quote right here says it all. If that ulcer eats its way deep enough to hit a blood vessel, you can have a massive upper GI bleed. This is an absolutely life-threatening situation. At that point, everything else takes a backseat. The number one top priority is to stabilize the client, period. Okay, exam alert. If you see a question about a patient with a GI bleed, your first moves are critical. Think ABCs. Make sure their airway is clear and get them on oxygen. Then, you need access, and not just one IV. You need 2 large-bore IVs. Why 2? Because you need to be ready to push fluids and blood products in fast. And all the while, you're glued to their vital signs and labs to see which way they're trending. The other nightmare scenario is perforation. This is where the ulcer literally punches a hole all the way through the stomach or duodenal wall, spilling all those contents into the sterile abdominal cavity. That leads to peritonitis. The red flags here are impossible to miss. A sudden, severe abdominal pain, and their belly becomes rigid, like a board. Their heart rate and breathing will shoot up, and they'll guard their abdomen. This is a surgical emergency, no question about it. So how do we handle this? How do we manage PUD to prevent these crises from happening in the first place? Let's shift gears and talk about the resolution, the key interventions, from surgery all the way to patient teaching. Now, when medications just aren't cutting it, or a major complication happens, surgery might be the only option. Two common procedures you'll hear about are the Billroth I and Billroth II. In a Billroth I, they remove part of the stomach and basically replumb it to the duodenum. In a Billroth II, they connect it to a different part of the small intestine called the jejunum. The goal of both is to reduce acid and get rid of the damaged tissue. Here is another massive exam alert, and just a critical safety point in general. After this kind of surgery, the patient will have an NG tube in place. You have to treat this tube like it's sacred. You never reposition it, you never irrigate it, and you never pull it out unless you have a direct, specific order from the surgeon. That new suture line is incredibly fragile, and messing with the tube could literally rip it open. Finally, the long-term game is all about patient education. It's about giving them the tools to protect their gut. The big takeaways are simple. Avoid things that irritate the stomach like alcohol, caffeine, and smoking. It's absolutely critical that they stop taking aspirin and other NSAIDs. And of course, they have to take all their prescribed medications, whether it's antibiotics for H. pylori or acid reducers, to let that ulcer heal and keep it from coming back. So let's end with a quick challenge to pull this all together. You've got a patient with a known gastric ulcer. All of a sudden, they develop this rigid, board-like abdomen and are in excruciating pain. What is happening, and what is your #1 priority action? Think back to those red flags we talked about. This is exactly where understanding the pathophysiology connects directly to what you do at the bedside.